And I think we are live. Let's see.
Are we live?
Okay, if you're there, type here in the comment section. All right. Hello, Shelly Green. Thanks. You're awesome too, Darius. I don't know if that's the dog, Darius, or is it a human being? I don't know. Kim Masters, peace. Can you hear us okay? Can you hear me okay? And what about, can you hear Dr. Yo okay?
I haven't talked yet, Mike. Just trying to get. All right, let's see who. I'm just trying to pull up my. I'm just trying to pull up my feed so I can see all the questions on my end.
Gina says yes. Yolanda says hi. We can hear you. If you can hear Dr. Yo, type in Yo in the comments.
Hey guys, can you hear me?
All right, both of us. They can hear both of us, so we're good.
Okay, let me just see if people in that logged into my room. Let me type it in here. 1 second, Mike. Like we do this every week. We didn't go to medical school for audiovisual. All right, let's see. Okay, they can hear me, so I think we are good to rock and roll.
Fantastic. Who has the first question?
Do you have a question on your end, Mike?
I think there's like a delay from. Okay, got one here.
Okay.
Why aren't they doing more to get people? Oh, so the question is about why aren't they doing more to get antibodies from people who've recovered from COVID-19? And then there's also another about. Okay, we have enough protection. Okay, so the question about do we have enough? Why aren't we doing more to get antibodies from people who've recovered? So this is actually in a clinical trial right now. So this is being investigated in randomized controlled trials of is this effective or not. There are a few cases of people who have who received the plasma from recovered patients, meaning these hyperimmune immunoglobulins. So based on these patients, it does look like it's promising, but there's still a need for a randomized controlled trial to show that it's definitively effective or not. So unless you're in this randomized controlled trial, you're not going to be able to get this fresh frozen plasma or this hyperimmunoglobulin from people who've recovered. So until the trial is finished, that's not going to happen unless you're enrolled in the trial. But hopefully they get this trial done soon so we can get some positive results out of that and then start giving that to more and more people. Once that happens, hopefully it does happen, then we can have this mass push to have more and more people donate blood. That way we can collect more and more of this plasma to give to more and more patients.
Mike, I've got a question on my end here. Can you hear me?
Yeah.
Okay. So this is from Paul Arnold. He goes, "Hi guys, any anecdotal information about the extreme California heat wave and its effect on coronavirus transmission?" So that's actually a pretty good question, Paul. I'm actually putting a video tomorrow, sort of about how weather and sunlight have an effect on coronavirus. There's been a lot of discussion in the news about, I think some government scientists have been reported to find that coronavirus can get killed by sunlight. Now, there's obviously a little bit more information we need to know exactly with sunlight, because there are 3 different types of ultraviolet light. There's UV, A, B, and C. UVC is what we use in the robots to clean some of the hospital as disinfecting robots. UVA and B is those ultraviolet lights actually penetrate Earth's surface. That's what causes the people that are tanning or skin burns. So the question is, we don't know right now is what this scientist found. Was it A, B, or C? If they're able to show that it was UVA and B, then that's killing the coronavirus. That's actually very promising to potentially suggest that the summer months with a lot of sunshine can have an effect on coronavirus. But if it's UVC, then it may not have an effect. In terms of weather, there are reports and studies that show that colder weather is conducive for viruses like coronavirus, which have an envelope around them. So we don't really know from what this current COVID-19 is going to do. But looking at influenza and the previous human coronaviruses, we can say that there might be, we can say the colder weather definitely protects those viruses, but with the warmer weather, it doesn't. Again, because it kind of messes with the envelope that's around them. So again, it's one of those things we have to wait and see.
Yeah, a lot of questions about ultraviolet light. What kills the virus is UVC. So the ultraviolet light has A, B, and C. And when we, for example, when we go to kill the virus on our N95 surgical masks, that's using, and it's basically irradiating the virus with UVC light. That's not what's really in the atmosphere. It's the UVA and UVB. So, and also in order to destroy the virus, you need very high intensity UV light, and it needs to be for a long duration. So also when you're getting exposure from the sun, that's hitting your skin, that's not hitting your insides. So the UV light from the atmosphere, although it might overall slightly reduce the spread of the virus, it's not going to be enough to just stop the pandemic. So that might contribute towards slowing down the virus, but it's not going to just totally stop it.
And Mike, I'm just to let everyone know, tomorrow I'll have a video on going a little bit more in detail about UV light, sunshine, and heat, and the effects on coronavirus. So
yeah.
Stay tuned on that.
Yeah, and also no bleach, please. No one use bleach or Clorox. Same thing. No one use this stuff, whether you swish it in your mouth. No, please do not do that. Or enemas, don't do that either. Do not use bleach to try to kill the virus. That will not do anything. You can use bleach to disinfect surfaces. All right, so that's fine, but please do not use bleach either on or in your body. That's dangerous, and it's not going to kill anything by doing so, except maybe yourself. So please do not do that. All right. Someone was asking about hydroxychloroquine trials. Unfortunately, the trials so far and all the numbers are not looking very good. The one that I'm most curious about is the one with hydroxychloroquine combined with zinc. That's in a randomized controlled trial, but we don't have those results. So it's too early to say whether it works or not, or whether it's safe or not. But overall, we have to wait for these clinical trials to finish before we can give a conclusive answer. But I'll say this much, I'm not very encouraged by what we're seeing so far. Dr. Yo.
Question, or you want me to comment? You know my thoughts on hydroxychloroquine. So
No, I was gonna hand you the next question.
Oh yeah, okay, it's probably better. Okay, so we have a question from who was asked earlier, where the Journey of Dawn Treater asked, looking forward to this, enjoyed last week. I want to know about the reactivation cases in Korea and China. They claim it is not reinfection. One article I read, some people might test negative, but they didn't fully clear the virus. Interesting and scary. So this is sort of a big question that sort of on everyone's mind is about this whole thing about reinfection. So one of the things in Korea they found was about 2% of the patients had or tested positive for coronavirus. And then in China and Wuhan, I think the numbers are something like 5 to 10% of the people. Now, there's obviously a couple of things to there's a couple of things going on there. One is we don't know. First is how accurate those initial tests were. You're seeing all sorts of data in terms of the specificity and the sensitivity of the tests that are being done. So we have to question if they were really cleared in the first place. The second question that investigators are looking at is, are these tests, when you're testing these patients again, are they picking up dead viral particles? So that's one thing that we don't know. And I actually wrote this down, is the, and if it's like a reactivation of the remaining virus in the body. So is this coronavirus, has it cleared in the first place? Is there some mechanism where it's hiding in the cells and then suddenly showing it popping out? And we don't know. I mean, that's implausible as that sounds. We're still getting a lot of information about the virus and antibodies and how effective they are. Because one of the other things is, even if you develop antibodies, is how long does it confer immunity? And all of these things are really important in developing a vaccine, because you could develop a vaccine and have antibodies, but if your immunity wanes off after a couple of months, it's really effective.
Yeah, so Gary and Karen are asking about INO, inhaled nitric oxide. So inhaled nitric oxide is a vasodilator. It dilates the pulmonary arteries, the blood vessels that go to the lungs. And this is a great question. I really think that for certain types of patients with COVID-19 who have ARDS, the ones who have lots of hypoxemia, meaning low oxygen levels, and the ones who don't have as much inflammation as you expect on the chest x-ray or on the CT scan, for those patients, I think they're going to have the most benefit from inhaled nitric oxide. The reason why I say that is because there's three main causes of low oxygen levels with COVID-19 ARDS. So when someone has COVID-19 to the point where they end up being in the hospital, whether they have just pneumonia or pneumonia that's severe enough to cause ARDS, there's three reasons why the oxygen levels go low. One is because of all the inflammation that's within the lungs. That's where we see tons of fluid and debris filling up the alveoli, and that lots of times causes collapse of the alveoli. So that's one reason. The other reason is because during ARDS, these tiny little clots end up forming within the capillaries. And so you can have these little micro tiny clots that are forming, and that actually is another reason to have low oxygen levels. And then the third, what happens with this ARDS is, and lots of inflammation, is you actually have the pulmonary arteries, the arteries that are going to the lungs, they're constricting, and that's causing pulmonary hypertension. And that in itself can cause low oxygen levels. So all three, when you combine them, it's a lot of hypoxemia that can develop as a result. So these are the patients that I'm most interested in inhaled nitric oxide, especially the ones that we suspect have more pulmonary vasoconstriction and pulmonary hypertension than compared to the ones who just have more inflammation. So we actually looked at inhaled nitric oxide for patients with ARDS in the past, but that was a different type of ARDS. Lots of these patients with COVID-19 have this other type of ARDS. So there's two types of ARDS with this new COVID-19. There's the traditional and then these new forms. So that's why I'm very interested to see what happens with inhaled nitric oxide, and I'm more inclined to give nitric oxide to someone who has severe hypoxemia more than I would expect based on their x-ray findings. Great question.
So I got a question over here. This comes from 63 Rambler. This person writes, what are the best chances for a compassionate use drug? And their second question is, which drug would be the most likely for a doctor to agree to use, given that everything qualifies as unproven? So I think if you guys saw my video about 2 days ago, you will talked about a drug called leronlimab, which, to be honest with you, I think this is the game changer. Michael Sheikh, he's also right now in my chat. Me and him had about a 2-hour conversation yesterday about leronlimab. I had been following this medication for a while. It is a CCR5 receptor blocker. Again, if you guys have been following my YouTube videos, you know that I believe cytokines are the central role in the pathogenesis of this disease. So if you look at some of the data, it's very, very promising. There are no side effects. It was an HIV. It was designed for HIV, to treat HIV in the CCR5 receptor, and it also has some effect on some of the cancer cells. So with cancer metastasis. So if you ask me personally, I feel like leronlimab is my drug of choice. I actually have a colleague of mine. He's an anesthesiologist intubated in a hospital in Florida. And I'm working on trying to get leronlimab as on a compassionate use basis. Remdesivir was declined. Couldn't get tocilizumab because of his liver enzymes, and hydroxychloroquine and azithromycin, zinc did not work for him. So right now he's on a trach and a PEG tube, and he's intubated. So and also I'm speaking with a couple of ICU doctors tomorrow regarding the use of leronlimab. Because a lot of them are just throwing their hands up in the air. They have no idea. So if you ask me, I think that's my drug of choice.
Someone asking about melatonin and the effects on the cytokine storm. So melatonin, I really wouldn't see how that would impact the cytokine storm. So I wouldn't expect in any way melatonin to be helpful for COVID-19. I don't think it's going to hurt, but I don't think it's going to be helpful in any way. And then someone else was asking about clots. So what's up with these clots that are forming in patients with COVID-19? So that's a great question, and it's a really tough situation because about 1/4 of patients with severe disease, we're finding clots in these patients. I personally know a lot of nurses and doctors who've had issues with clots from COVID. I know dialysis nurses that are saying they have to change the filters on the dialysis machines because it keeps clotting up. And there's probably more clots than we're even aware of, because when someone comes in with a pneumonia, such as with COVID, we don't usually think that they also have clots, because clots is another diagnosis, and we don't think, well, this person has more than one diagnosis. But the studies are showing, based out of a study done by the Dutch and then another study done by the Chinese, that about 25% of patients with severe disease have clots. And these clots are not just in the lungs. Usually the most common place for clots to be are in the legs, and then they can break off and travel up to the heart and then go to the lungs. But also there's clots that are in the brain, so they're causing strokes. There's clots in the legs that are causing decreased blood flow to the legs. And actually there's a celebrity Broadway actor who had to get his leg amputated because of this reason. Just like in Dr. House, except Dr. House, he kept the leg. But this guy, he had to have his leg amputated because of a blood clot. So they're definitely occurring, about 25% of patients with severe disease. Why? It's probably related to the inflammation that's going on from the cytokine storm, in addition to the stimulation of the ACE2 receptor. See, when the virus invades, the ACE2 receptor is located not only within the alveolus, but it's also located within the capillaries that surround the alveolus. So you have not only the viral invading the alveolar cell, but you also have the virus latching onto the ACE2 receptor on the endothelium of the capillary, and that is the trigger for thrombus formation, for clot formation. That's what's going on there. So once you have all these tiny little clots developing, they can come together and form bigger clots, and then they go back into the circulation after the capillary. They go back to the heart, and then the heart pumps that clot to the rest of the body. So that seems like what's going on with the clots. And I actually just made, or in the process of making, a full video dedicated to this topic, which I'm going to post tomorrow. So that's going to be a full, at least 10-15 minute video just dedicated towards that topic. Aspirin for clots, how we treat these things is, it's a really difficult way to know, because we don't like to treat things unless we see it. So if only 25% of patients with severe COVID disease have clots, that means we shouldn't be treating the people who don't have clots. The problem is, it's hard to know who has clots and who doesn't. Some people say, well, why don't you just do the tests to figure that out? Easier said than done, because for a couple of reasons. One, because we're in a pandemic, and when you do a test on a patient, not only does it carry more risk to that patient, for example, if they're very sick in the intensive care unit, and then you have to go and transport them for a CAT scan to look for a clot in the lungs or a clot in the brain, that's easier said than done. The other thing you can do is do an ultrasound of the leg, but just because you don't see a clot there doesn't mean they don't have a clot. So trying to figure out if they do or don't have a clot is easier said than done. And to just treat everyone as if they do have a clot is a big deal, because the downside is, with these blood thinners that we give, they can cause bleeding to the point where it's life-threatening. So the decision to treat or not treat with a blood thinner is a big decision, and it's hard. It's a hard decision, and that's what all doctors are facing right now in this country. So whether it's in the ER or in the intensive care unit, these are the questions that we have to ask ourselves on a case-by-case basis. Should we or shouldn't we treat them as if they have a clot?
Mike, there was a follow-up question to that. Well, if you want to take it, how quickly those huge clots take to develop?
It's hard to say. It's hard to know. It probably depends on underlying genetic factors. A lot of us in the population have certain genetic predispositions to clotting, and we're not even aware of it. So that's one aspect of it. The other aspect is, how severe is the infection? My guess is, if it's a severe infection, by the time you start seeing inflammation in the lungs, that's when the clots probably start to develop. No way to really put a timeline on it. It's probably within a couple days of the onset of the infection. Sometimes we have clots sitting in our bodies that don't even cause symptoms. They're just sitting there and we don't even realize it. And it's not till later on, when something worse happens, where they can cause symptoms. So lots of times people have clots without even realizing it. And sometimes we accidentally catch a clot when we do an ultrasound study or a CAT scan, and that we realize that patient didn't even have symptoms of a clot, but they do in fact have a clot. D-dimer tests are very sensitive, but are not meant to be used for diagnosis of blood clots. That's right, Princess T, 1979.
All right, Micah. I love these. I love these screen names. Okay, so there is someone named Sirius Allen who had posted on my community wall, were there not several tests with rhesus monkeys that proved after initial infection something about recovery and reintro? Monkeys had 1-day temperature, then no further evidence of disease. Now, I think that Sirius Allen is referring to Remdesivir. There were a couple of clinical trials done with rhesus monkeys, and it looked like they were able to, if I can remember correctly, decrease the pulmonary infiltration on, I think, post day 0, 7, 14 after inoculation. So one of the things to remember is, when you're doing these phase, like pre-phase and phase 1, 2, 3 clinical trials, there's no guarantee that just because you passed one phase that it's going to pass the next clinical phase. One of the reasons I put those 3 medications I did on my video, remdesivir, tocilizumab, and lorazumab, was because they were all three in phase 3 clinical trials, meaning they had already jumped through several different hoops. Now, the study, what's disappointing about remdesivir is even though they looked at the rhesus monkeys and it was very promising, the study that came out of China, which the WHO took down, it was not associated with difference in time to clinical improvement compared to a standard care control. And so what they found was 13.9% of remdesivir patients had died compared to 12.8% of patients in the control. So the difference was not statistically significant. And what's also important about this China study is that it was actually a randomized control study, meaning it's the gold standard. So when you're looking at studies again, if it's randomized control and you're getting some data and evidence, no matter how excited you are about the results or what you're expecting, it's evidence is data is data. And so that's why there's been a lot of disappointment about remdesivir. And to be honest with you, I'm not surprised because I feel like, again, I'm going to go back, harp on this. I'm actually posting a video a little bit more on cytokines on Tuesday, where I'm actually going to be sort of extrapolating on the entire disease pathogenesis. So I personally think that antivirals, they play in sort of an adjunct role in fighting this infection.
Someone was asking about, does walking help reduce the chances of getting clots? So yeah, you're definitely more at risk of developing a clot if you don't move around. That's why people who go on long trips, such as long airplane rides to another country from like here to Australia, these are people who are at higher risk of developing clots, or like a long bus trip, long car ride. So it's definitely important to stay active, walking around, exercising, jumping jacks, whatever, to reduce your chances of getting a clot. Although certainly there's people who still are very active and exercise a lot who still get clots, so it's not necessarily a given, but that there's lots of different factors that go into who develops a clot. Certainly activity level is one of them, so stay active. It's better than not being active. Another question was about ACE2, about ACE inhibitors and ARBs. So this is something I've talked a lot about before in my other videos. So right now, there's actually a study that just came out recently looking at patients who were hospitalized with COVID, and they looked at which patients were continuing the ACE inhibitors and ARBs, and they compared that to people who weren't getting them. And they tried to match up as many of the variables as possible. And they did find that the ones who were taking the ACE inhibitors or ARBs, such as losartan, ACE inhibitors like lisinopril, ARBs like losartan, valsartan. So the ones who were taking these medications, they did have a lower mortality rate compared to the ones who weren't. Now, some people might say, well, what about in New York, where they looked at this people on ACE inhibitors and ARBs, and it didn't show that. Well, you have to realize that was a different kind of study, because that one was based on data collected from a hospital system, the Northwell Hospital System, based out of a bunch of hospitals in and around the New York City area. And all they did was have their computer go ahead and calculate which patients died and which patients were on ARBs and ACE inhibitors. So that data showed that there wasn't a benefit, but that data has to be taken very lightly with a grain of salt. Here's why. Because ACE inhibitors and ARBs, they're given for multiple reasons. They're given for high blood pressure most commonly. They're also given for people with chronic kidney disease. They're also given for people with heart failure. So, for example, let's say someone is taking an ARB like losartan, and they're taking it for high blood pressure, and they're 45 years old. Now, compare that to someone who's 85 years old, who has heart failure and chronic kidney disease and high blood pressure. Well, you can't compare those two groups. One is going to be much higher risk of dying from COVID than the other. So that's why you have to have these variables accounted for when comparing the two. So there's going to be more and more studies based on these ACE inhibitors and ARBs. And most importantly, there's going to be a randomized controlled trial looking at these. So this is something I'm very much looking forward to, and I can't wait to make a video once these results come about that.
Got a question here, Mike. If you start treating with something about treating with antivirals early enough. So there's some discussion that hydroxychloroquine, azithromycin, zinc, if you started early in the disease or with early symptoms, that it has more benefit. And that's because most physicians I've been talking to are finding that towards the middle or moderate to severe symptoms of the disease, it's not really having that much of an effect. But here's the main question. Would someone have recovered using their own immune system without the aid of any of these medications? Would they have recovered? So again, this is why we need those studies, so we can see if these medications are really working, or is it really our body's own immune system that is actually doing most of the fighting. Now, keep in mind, 80 to 85% of patients are only experiencing mild symptoms, and a lot of them are not getting hydroxychloroquine and azithromycin and zinc. So it makes me believe that our own immune system is able to fight this infection. Is that 15 to 20% that are susceptible to the severe form, and of that, a much more smaller number are succumbing to the virus. So again, the investigation has to be into why those people are susceptible. And when you look at a lot of the data, they are multi-organ failure, and that is due to, personally, to cytokines. I'm going to keep on harping back and coming back to that point.
Yeah, someone was asking about vitamin D, or should they be taking a multivitamin or vitamin D? Well, I'll start out this answer by saying that I myself do take vitamin D. I take about 1,000 to 2,000 IUs per day. So I'll tell you why I take it. The chances of me being vitamin D deficient are probably pretty good. Being somewhere where I'm not getting a lot of sunlight, especially during the winter months, chances are my vitamin D level is low. Now, ideally, I would get my vitamin D level checked with a blood test and see if I'm low or not. That would be the ideal situation, but that's just something I haven't done yet. And most people, it's just not practical for them to go and get their vitamin D levels checked. Although, probably a good thing, especially if you're not getting a lot of sunlight, like if you're not living in the Caribbean or something, chances are you're going to have low vitamin D levels. Now, there was recently a meta-analysis where they looked at a bunch of studies that had to do with people's risk of getting upper respiratory infections with the flu and with other coronaviruses. So this was before COVID was a thing. And what they found was that the people who were vitamin D deficient, if they were the ones who were taking daily doses of, say, 1,000 to 2,000, something like that, IUs every day, those were the subset of people who were most likely to have a decreased risk of infection, meaning upper respiratory infection. So that's the rationale. It hasn't been specifically looked at for COVID-19, so we don't know if it has any impact on COVID-19 or not. So that's the reason why I take vitamin D. I think for most people, taking 1,000 or 2,000 IUs every day is not going to cause harm. You don't really get those toxic effects of vitamin D until you start running into the 50,000 to 100,000 IU range over the course of a week or so. But again, ideally, you want to have your levels checked, and if you are deficient, those are the people who are going to have the most benefit from taking vitamin D.
And Mike, along that line, they've actually done studies where healthcare workers, especially people that work in the operating room, like myself, have low vitamin D levels. So before I started residency, I had vitamin D was normal. And I remember my second year of residency, I got my vitamin D levels. It was so low because we're literally in an operating room, not seeing any sunlight. And if anyone's worked in an operating room before, there's usually very little windows. So
yeah, someone said she lives in Florida, and I missed her question. She lives in Florida. I think she was saying that she works in shift, or due to her shift work, she doesn't get much sun, and that's why her vitamin D levels are low. Yeah, I mean, just because you live in a sunny place like Florida or the Caribbean doesn't guarantee that your vitamin D levels are normal. So it's certainly, vitamin D, it's really not going to cause harm unless you're taking big doses. And then someone was asking about Diamox. So acetazolamide, which is Diamox, This is an inhibitor of the enzyme called carbonic anhydrase. And the reason why people, I think, are asking about this now is because this people are comparing the certain type of ARDS that we see with COVID. They're comparing that to HAPE, which is high altitude pulmonary edema. But even though there are some similarities, you can't say that this is the same pathophysiology. There are two different pathophysiologies going on here. So you can't connect the dots of why giving Diamox to patients with COVID-19 is going to have any benefit. I can tell you there are no randomized controlled trials of acetazolamide of Diamox because there's no reason to believe that it would work. The way that this medication works is by inhibiting this enzyme, and it actually makes your blood more acidic. It decreases the pH of the blood. And in that process, it kind of tricks the brain into thinking like, hey, my blood is more acidic, therefore I need to blow off more CO2 in my lungs. And when you blow off more CO2 in the lungs, there's less CO2 in the alveoli and there's more oxygen in the alveoli, and that will minimally get your oxygen levels up, barely. So that's the way that it works when you give someone Diamox. Now, when someone has high altitude pulmonary edema, the main treatment is actually not with Diamox. Diamox is used to prevent HAPE from happening. So if someone's about to go climb a mountain, climbing Mount Everest, you say, here, take some Diamox before you climb. That way you reduce your chances of getting HAPE. So Diamox, if you understand the pharmacology of Diamox and the pathophysiology of what's going on with COVID-19 and ARDS, it's not going to have any benefit to these patients. And that's why no one's looking at it in trials, because there's no reason to believe that it would have any benefit.
So I got a question from Jeremy Nish, and he wrote, I wrote an article about how I believe this is more of a blood disease than a respiratory one. I believe a lot of damage from this disease is loose iron and virus infected red blood cells. Thoughts? So I'm sure you've probably seen my video on hemoglobin, my theory behind it. And, you know, I feel, so these are my thoughts. I feel like this is still a respiratory disease. The end game is the respiratory system. But I feel like the etiology of how we get there is not as clear. It's a little bit of a muddy picture. I don't think it's the virus just attacking the lungs, even though I think it is playing a role in the pathogenesis of the disease. Now, it's interesting because the virus, how it attacks the red blood cell, we're not exactly sure. I've actually been talking with a couple of doctors and a couple of other people, actually been through YouTube and social media. There actually might be a way to link it. And I'm actually going to be looking over a bunch of studies and posting the video on this on Tuesday of how actually we might be able to link COVID-19 and the red blood cell. Again, it would all be very theoretical, but I think your article and what I was basing my video on was that Chinese study, which was an in vivo study and using a computer model, which showed that the E2 glycoprotein on the virus could damage the porphyrin ring of the red blood cell, causing sort of hemolysis and iron ions to be act as free radicals. Again, very theoretical. The main question was, how can a virus attack red blood cells? Just keep in mind, viruses don't like to attack cells that don't have a nucleus, and red blood cells don't have a nucleus to it. So I think I might be able to link both of them. So just give me about a day or two and I'll post the video. It's definitely very theoretical. I'll say this, Dr. Mike and I, we're not the type of people that want to spew conspiracy theories or we have our own concoction, but we do like to, you know, once in a while throw out an idea or a theory. And even though we may have a hard time proving it, just for food for thought. So that, I think there's definitely validity to it. So just give me a day or two and I'll explore that.
Someone was asking about N95s, wearing them for a long time, causing headaches. It's certainly possible. There's lots of different triggers that cause all sorts of headaches, so it's certainly possible. You know, it's definitely uncomfortable, you know, wearing the N95, and then lots of nurses, sometimes what I'll do is put a little kind of adhesive tape here that serves as a cushion to where that metal bar is. That way you give your skin a break from all that pressure. Yeah, USERF, sorry, no ACE2 receptors on red blood cells. That's true. Yeah, and the other thing too is we know that it's a long process primarily. Not to say that other parts of the body aren't affected, but with this process, we know based on the low PO2 to FiO2 ratio that it's a process within the lungs that's preventing the oxygen from moving from the air that you inhale into the blood. So if you were strictly a hemoglobin process, you would expect to have a normal PO2 to FiO2 ratio. So for example, like methemoglobinemia, where it's a hemoglobin issue, and that's where you get low oxygen saturations, but the PO2 to FiO2 is normal. Okay. What is the percentage of dying if you have coronavirus? Well, it's about 1%. Again, the numbers, it's hard to know exactly, but it's around 1%.
Mike, I've got this was a question asked earlier from Journey of Dawn Treater. She asked, COVID-19 seems to be attacking epithelial cells throughout the body, usually starting with nose epithelial cells. What can we do to strengthen epithelial cells? Sounds silly, but it's in beta carotene, good for epithelial cells. And so here's the thing with a lot of these supplements and these nutrients that we can take is they definitely play a role in in balancing our immune system, in helping with cell growth and sort of the functions of a lot of our metabolism. But to come out very conclusively and state that this is going to help with COVID-19 without any evidence would just seem a little premature, and not something I would want to say. Beta carotene is an antioxidant, as you mentioned, and it's a precursor to vitamin A. You can find it in carrot, spinach, pumpkin, sweet potato, and it does have a role in preventing skin damage. Now, just remember, COVID-19 has a strong affinity to the receptor, but how it enters is through your nose and mouth and through your eyes. So it works its way down. And could strengthening your epithelial cells? I mean, hypothetically, yes, but there's really nothing to say that taking beta carotene is going to act as some sort of preventative mechanism. Like I said, it can definitely help in balancing your immune system. So if you do get exposed, you have sort of what I like to call an optimized immune system ready for the fight. But in terms of like preventing it and strengthening cells, it's just more theoretical than really based on evidence.
Yep. And so someone is asking about emphysema and asthma. So yeah, definitely asthma and emphysema, there's actually a lot of overlap between the two, but they are two different diseases, and some people actually have both. I have patients that have both asthma or the asthma progresses to emphysema. So asthma is mainly, 90% of asthma is an allergic disease, meaning it's based on an allergic reaction within the lungs. 10% of asthma is based on irritants. So like if you were to inhale smoke or inhale secondhand smoke, the irritant from that can trigger the asthma. So there's two types of asthma. There's allergic and non-allergic. But either way, there's inflammation within the lungs. And when you have this inflammation, that is actually makes it harder for the lungs to clear infections. So viruses and bacteria that invade into the lungs, we use our cilia and other means, mucus, to clear those viruses and bacteria. When you have all this inflammation in the lungs, it means that you can't do that as well. So inflammation with asthma, also same thing with chronic bronchitis, which is overlapped with emphysema. Both are part of the COPD spectrum, chronic obstructive pulmonary disease. All these things have inflammation within the lungs. And inflammation is bad. It's going to mean to be more susceptible to getting the virus if you don't have those things controlled. So if you have asthma, you're going to want to be making sure that you're following with your lung doctor or whoever's managing your asthma, maybe your allergy doctor, or your primary care doctor. Make sure that your asthma is under control so that you're minimizing the amount of inflammation within the lungs. And then the same thing goes for emphysema, COPD, which is emphysema and chronic bronchitis. So make sure it's controlled. And of course, besides looking out for COVID, you also want to be up to date on your other vaccinations, such as pneumococcal vaccination to prevent or reduce the severity of pneumonia, specifically streptococcal pneumonia, because there's different types of pneumonia. And also the flu vaccination too. You want to make sure you don't want to get that. Or if you do get it, you reduce your chances of severity of disease. So, and also look, last thing you need, whether you have healthy lungs or not, or whether you have asthma or COPD, the last thing you want is to have more than one infection on top of that. So to have flu, to have COVID at the same time, I mean, one of these things is bad enough. You don't want more than one of these things. You don't want any of these things. So the more you have, the worse it is.
So I got a question about, can asymptomatic patients suddenly develop ARDS, and or patients have to have some respiratory symptoms? So that's actually a pretty good question. You know, one of the things is how quickly from the time someone gets infected till the time they get, let's say, ARDS or the severe form of severe infection. So at least from my experience, it seems that patients, just remember there's an incubation period of 1 to 14 days. So that means that you could get exposed on day 1 and you can show symptoms on day 13 or 14. So from my experience, I'm seeing patients with COVID-19, speaking with friends and colleagues of mine too that have come down with it. There isn't really a sudden development, but you're usually seeing some respiratory symptoms such as a cold, a flu, a sore throat that suddenly progresses to, oh, I'm having shortness of breath, I'm having difficulty breathing, to then having to get admitted to the hospital. There's not someone that wakes up and says, oh, I have ARDS, or I'm having really bad symptoms. It seems to be a progression. The time really, there are definitely differences. There's some people after like a week of respiratory symptoms, and then there's some people after like 2 or 3 days after having the respiratory symptoms, they will start to develop some of the severe form. And why? Again, there's so many different theories. A lot of it has to do with underlying conditions. If they've had asthma, COPD, hypertension, cardiac disease, are sort of some of the big reasons why they are having, while they'll have a quicker onset of some of the severe form of the disease.
Yeah, someone was asking, should they get a pulse oximeter at home? That way they know if their oxygen levels are dropping or not. Generally speaking, I recommend that people don't get it, but the ones who should get it, in my opinion, would be the ones who have lung disease or heart disease, or are at very high risk of getting severe disease. Again, this is a tough question to answer for a general census. If you were my patient, if you said to me that I don't have any lung problems, I'm otherwise young and healthy, and I don't have any real reason to believe that I would get very sick from it, then I would say, well, it's not worth buying the $50 to get the pulse oximeter. Now, someone who has, let's say, emphysema, COPD, chances are they might have a pulse oximeter anyway, or they should probably get one for that reason anyway. But especially if they were to get COVID, that'd be one way to know that their oxygen levels are dropping, because whatever that number is, 30% of people don't have any symptoms. The most common symptoms, fever, dry cough, and shortness of breath. But not everyone has symptoms, and it is some of these patients, especially the study done in Italy, showed that some people had very low oxygen levels without actually feeling short of breath. Again, not all of them, but there's a good subset of patients who actually had these low oxygen levels without feeling short of breath. So it is a good question, and no one's going to fault you for getting it. I just don't think that for the general population, most people are not going to benefit from that, but it's not going to hurt to get it. And then the other thing too is you run into other issues where you have people with fake nails or nail polish, and that can give you artificially low numbers. So someone might think, oh my God, my oxygen levels are low. even though I don't have symptoms, but my oxygen levels are low, I should go to the hospital. And it might just be that their nail polish and or fake nails are causing a falsely low reading. So again, you have to be cautious interpreting the numbers. The main thing for me is going by the symptoms. Most people that do have low oxygen levels are going to feel short of breath. That's most people. And the other thing is, if you do have a pulse oximeter, by the change. So if you're normally saturation for most people is 100%, now if all of a sudden you drop to 90%, that's more concerning than someone who's always hovering around 92, 91, 90%. For example, someone with emphysema, COPD.
So I got a question again from Mr. Boichi. I think that's how you pronounce it. He asks, can I ask you about reinfection? What are your thoughts? We just talked about this a little bit earlier. I'm just going to touch upon it because I know probably on Mike's side there are going to be people asking this question again about reinfection. We really don't know right now. So the thing with reinfection is we have to question the veracity or the sensitivity and the specificity of the initial test. Were the tests even valid? When someone is negative, was it really a negative test? So the second point is that the reinfection, or when they're testing positive a second time, is it really a live virus, or is the test picking up a sort of viral particles or the dead viral particles? And that's a question we really don't know. And the third question, which again we have to investigate, is coronavirus or the COVID-19 virus, is it sort of hiding and masking from the immune system and then having to reinfect? That, again, it might sound very theoretical and implausible, but there are many other infections that have done it. For example, like HIV, which can hide in your DNA and then suddenly just pop out. So is the same thing going on here? We really don't know. But we are seeing, I know, as I mentioned earlier, about a 2% reinfection rate in South Korea and about a 5 to 10% reinfection rate in China. But there's still so many unresolved questions that we need to ask before we can jump to any conclusions.
Yeah, someone was asking about loss of smell as a symptom. Yeah, so there's a study out there that shows about 30% of people, I think this is in South Korea, showed that they presented with loss of smell. So loss of taste, loss of smell. And it's very plausible that this happens because we know that we have the ACE2 receptors in our nose. That's where so the olfactory nerve is up here, and that's where we have our sense of smell. So the ACE2 receptors are located here, but they're also located at the back of the throat. They're located in the mouth as well. So it's very plausible that when the virus is attacking the ACE2 receptors in these locations, that's why they could have loss of sense of smell and taste as well. Some patients, we believe that when the virus stays up in here, in this region, sometimes that's why most people don't get the severe symptoms of shortness of breath or ARDS or pneumonia, whatever. But when the virus travels down, or if you inhale it down to the lungs, depending on how much of that virus you inhale, that might be a reason as to why some people get sicker than others. There's other factors most likely that are going into that, but that's definitely one of them. And then the other thing is IL-6, interleukin-6 is known to play a big role in the cytokine storm, in the beginning of the cytokine storm. IL-6 is actually inhibited by estrogen. So it's thought that, well, if some people have, like women, have more estrogen, maybe that's why it's causing less severe disease, generally speaking, in women compared to men. But again, we don't have that evidence for sure. This is based on either small studies or speculation. So again, what we do know is from things that have been studied in the past, such as we know that estrogen inhibits IL-6, and we know that IL-6 is a big part of the cytokine storm. But to make the leap from, well, is that the reason why estrogen is definitively the reason why women have overall less severe disease compared to men? It could be, but we don't have direct evidence of that. Then someone was asking about ventilators. So, ventilators, I know I made a video, do ventilators save lives? And the answer is by themselves, they support life. So they can be the bridge, they can get people to survive an illness in the form of life support. Ventilators themselves are not a cure for any disease. They're a form of life support. A lot of people have the misconception that if you put them on a ventilator, that's the reason for them dying. And that can be the case if we have the ventilator settings, if we're doing it wrong. And it's hard to know if we're doing it wrong or not because there's different subsets, different phenotypes of these patients with ARDS, with COVID-19. There's a study by Dr. Gattinoni in Italy where he demonstrated that half the patients have this L phenotype of ARDS, and then the other patients has H phenotype of ARDS. One meaning the L phenotype, which stands for low elastance. So this is the one that's going to have more compliant lungs and less inflammation on the X-ray and the CAT scan. That's one type of ARDS, the L phenotype. Then there's the other one where you have the H type, which stands for high elastance, meaning low compliant lungs. That's the ARDS that everyone is already familiar with, where you have tons of inflammation within the lungs, where you have alveoli that are filling with fluid and fibrin deposition, meaning all these different parts of cells and proteins that are just accumulating there and completely filling up the alveoli and causing the alveoli to collapse. That's the ARDS that most people are familiar with. So if COVID-19 patients have ARDS that are two different types, that means we have to employ two different ventilator strategies when these patients are on ventilators. So for one group of patients, we're going to have to change the ventilator settings to accommodate those patients. And then for the other group of patients, we have to play with the dials on the ventilator to accommodate those subset of patients. So it's not one size fits all when it comes to COVID-19 ARDS. And this is new to us. This is groundbreaking. This study just came out based on the patients in Italy of COVID-19 ARDS. This is not even a month ago. So this is all groundbreaking stuff. And this is newsflash for not just the general public, but also for those who are in the healthcare field.
Mike, I got a question about, can you tell us from Scar Guy, AKMS 74UGY, I don't know what that name means, but can you tell us if the hydroxychloroquine is not recommended for someone with liver disease? So a couple of things to mention. A lot of these drugs are going to be metabolized in your liver. So it's and you excrete it in the kidney. So most, I'm not going to say every drug, but most drugs are going to be excreted in the liver. It's a balancing act that we have to play, because you could have decrease in liver function, but if there is a life-saving medication, then you might want to take it. See, I come from that school of thought that just because you have, let's say, some sort of liver disease or a decrease in liver function, that you should, like, all drugs that cause liver toxicity are completely off the table. Like, everything has to be taken in the context of sort of what we're dealing with clinically. And that's why we're clinicians. We have to deal with risks and benefits all the time. Hydroxychloroquine is metabolized in the liver, excreted in the kidney. So just right off the bat, someone would say, well, don't give it to someone with liver disease. But again, when you're looking in terms of a clinical context, it's someone, if you're talking with someone with liver disease, let's say they have some, like, a severe or maybe a moderate form of COVID-19, and the only option is hydroxychloroquine, do you just hold off on the medication because you have liver disease? See, it's a really tough call to make. So you have to see the degree of liver function, sort of the sequelae or the disease pathology of the patient, like where they are, and if there are other choices to make. So it's very hard to say, like, oh, I recommend or I don't recommend. You have to take a look at it from a sort of the entire clinical picture.
Now, Gina was asking about, she read on Facebook that if you hold your breath for 10 seconds, that means if you're able to do that, then you don't have it. No, that's totally false. That has nothing to do with anything. Now, another one was asking about indomethacin, and someone else was asking about NSAID. So indomethacin is an NSAID, meaning a non-steroidal anti-inflammatory drug. So steroids such as methylprednisolone, solumedrol, such as prednisone. These are steroids. Specifically, these are called glucocorticoids or corticosteroids. Then you have non-steroidal anti-inflammatory drugs. These are things like Advil, ibuprofen, Aleve, indomethacin. So those are examples of NSAIDs, non-steroidal anti-inflammatory drugs. What we know for steroids is that they can either worsen some infections or they can reduce the severity of some infections. It's very a hit or miss thing. Some patients, for example, tuberculous meningitis, we give them steroids because the damage from the inflammation to the brain is so bad that we have to reduce the inflammation while we still give them drugs to treat the tuberculosis. So that's one example. But then in other cases, if you give people steroids, they can have worse disease, worse infection, whether that's from a virus or bacteria. So really, it depends on what we know about that specific infection. For COVID, we don't know. The recommendation right now by most medical societies is to not give steroids for COVID-19 infection unless they have severe ARDS. That's really the standard. But again, that's not a very concrete yes or no. That's the recommendation, even though we don't have much evidence to support or refute that recommendation. So it's really unknown if you give steroids to COVID patients, do they get worse or do they get better? We don't have studies. And steroids are being looked at in randomized controlled trials, so hopefully we get an answer to that soon. Now, that's what we know about steroids. Can we apply that to NSAIDs, non-steroidal anti-inflammatory drugs like indomethacin or ibuprofen? The answer is we don't know. Given these drugs, we do know they have lots of side effects. We know that they cause stomach ulcers, ulcers in the intestine. They cause inflammation within the stomach, gastritis. They impair your kidneys. They cause kidney damage. They can cause higher blood pressure. So does it make sense to give someone NSAIDs to COVID-19? No. And in fact, whenever someone comes to the ICU in general, we always shy away from giving NSAIDs because of the side effects. Yes, they do reduce pain. Yes, they do reduce fever, and that can have some benefit. But if someone has fever, we're always going to reach for Tylenol first before we give the NSAIDs because NSAIDs carry way too many side effects for someone who's in the intensive care unit and is already prone to having kidney damage while they're in the intensive care unit and already prone to having stomach ulcers and inflammation of their stomach. So that's kind of the take on giving NSAIDs to people with COVID-19, especially in the ICU. I don't see why specifically from a pharmacologic standpoint, from a pathophysiology standpoint, why NSAIDs would be beneficial for these patients. I don't see a specific reason why, oh yes, if we give an NSAID, it's going to inhibit this cyclooxygenase enzyme and therefore impact the cytokine storm. I don't see that connection there, so I don't see why they would be of benefit. Therefore, my recommendation is people should avoid NSAIDs unless they have a specific reason to be on them, but otherwise, generally speaking, avoid them if you can. All right, Dr. Yo, looks like it's been an hour. It's 8 o'clock Eastern time now.
Yeah, and I just want to apologize, everyone. I wasn't, I'm being distracted. So a friend of mine is, as I mentioned, he's an anesthesiologist in Florida right now, and he's dying of this disease. He's on a trach and peg, and I'm trying to get him leronlimab, and I'm sort of texting with his family right now as this chat is going on. So I just want to apologize to everyone. This is, obviously this is affecting all of us, including people in the medical profession. It's affecting a lot of our friends and families and loved ones. So I just want to apologize to everyone for just being distracted for the last 10 minutes, but just got some good news. So just trying to coordinate things. I got one more question. Someone said, Dr. Yo, are you optimistic at all about the state of research until now? To be honest with you, I am. I really strongly believe that we are going to unlock this this virus and this disease. There's a lot of really, really smart people that are. We have the entire medical community that is really on top of this virus. Leronlimab is my favorite. I've been actually talking with a couple of people from YouTube, a couple of ICU doctors. We're going to be able to map this whole thing out pretty soon. You know, and you guys are following Dr. Mike and his YouTube channel, and he's on top of things. So, and you can see there's a lot of promising things. What we thought the virus was doing about 2 months ago, we have a better handle, we have a better understanding, and I'm pretty certain in the next couple of weeks we're going to see hopefully a vaccine. And I'm putting a lot of stock into leronlimab. I know Mike's probably like, what is going on? What is going on here? But I have a lot of faith in the drug. So yeah, I'm very optimistic.
Yeah, someone else was asking about is Georgia reopening too soon? In my opinion, yes. I think that the sooner you reopen, the longer the problem is going to be. The main issue is you have to have enough tests before you reopen parts, and the reason being is because that's where you can identify the people who have infections, and when you're able to do that, you're able to isolate the people who do have the infection and quarantine them. So again, the sooner you let up on virus, the more it's going to come back. Unfortunately, that's just the way it is. I know it sucks. Believe me, I hate being not able to go anywhere and do anything. It sucks. I'm not going to lie. I mean, I wish I could be out and about and hanging out with friends and socializing. You know, yes, we can FaceTime, which is good. We can Skype, which is good. You know, we can call family members. That's good. But it's what we have to do for now as a collective society in order to reduce the numbers. And the harder we go now, the more intense we go now, the sooner it'll be over. So that's the bright news with that. And we need more tests. You know, the testing is going to be a crucial part in being able to isolate who does or doesn't have it. And the antibody tests, a lot of people are asking, it's, you know, the big thing with antibody tests in terms of which ones are actually accurate. We don't know how accurate they are, and the ones who do test positive, that's another question, is can they be reinfected? And it looks like that is the case with some people, but my suspicion is most people who do get it and they develop antibodies, my suspicion is that they are very much less likely to be reinfected by the virus. But again, I don't have any studies or data to back me up on that. That's in process right now as we speak. So that's where we're at. Unfortunately, we don't have all the answers, and we're hoping more and more answers are coming soon. So when we get those answers, when we see more and more studies coming out, that's what we want to do for you, is bring this to the public and get out the most accurate information, and that's also the most up-to-date information. So that's why we're here, and so that's why we plan on coming back next Sunday if you guys are down for that. So if you want us to come back next Sunday, put a yes in the comments, and we'll plan on doing this again. Your thoughts, Dr. Yo?
Yeah, no, exactly. I really enjoy doing this. You know, one of the things, you know, Mike and I, we were just talking about was how much we are learning. I mean, just for us to go research and go back to our own med school and residency textbooks and a lot of new ideas, and just being able to connect with people from all around the world has just been such a blessing and something I'm very grateful for.
All right, Jen Star says absolutely. Eileen says yes. A lot of people saying yes. All right, so why don't we plan on, we'll keep you posted with the actual time, but we'll plan on next Sunday around the same time. And we'll let you know through Instagram, probably YouTube community as well, the exact time of when we're going to do it.
Yeah, in the meantime, if you guys have any questions, you can send us a message. If you have any, as I just mentioned on my chat room, if you guys have any family members or friends that are really, really sick, that are intubated, that they're giving no hope for you guys, send me a message. You can find my email on my YouTube page. You can hit me up on Instagram at ECA Wellness. And you can also message Dr. Mike. He can get you in touch with me. have a couple of things and a couple of resources that we all have to be working together. And so just you guys can get in touch with me, and I can throw my theories out there. I'm talking to a couple of ICU docs around the country right now about what I think is maybe a possible way of treating this illness. Again, there's no guarantees, but yeah, like I said, you guys feel free to reach out to me, and we can brainstorm things.
All right, so I have a video about clots with COVID-19, and I'm going to post that tomorrow, probably tomorrow afternoon. So you could also ask questions in the comments section there, but also you can ask questions. I try to get to all of them. I can't always get to all of them, but you could also hit me up on Instagram. So Dr. Hansen. That's my Instagram handle. So I'll type that in now, so that way you have that. And,
Mike, what is your Instagram? I'm going to type it on my end.
Oh yeah, so it's Doctor spelled out DOCTOR. Hansen, Hansen. Laura May, thank you. Yeah, that's my Instagram there.
Mike, that's your Instagram. Okay.
Yeah. Get some sleep, they say. I think they're talking to me. All right, guys, it's been fun. Looking forward to doing it next week. And in the meantime, everyone stay safe, be healthy, and take care.
Yep. Thanks, guys. Have a good night. Bye-bye.